Good afternoon, colleagues. Today I'm inviting you to join me on a journey to explore what we know about and what's new in the management of recurrent pregnancy losses. I'm Elzaan Olivier, and my supervisor was the spectacular Dr. Mbungu. A miscarriage is a traumatic loss, not only of a pregnancy but also of a couple's hopes and dreams for the future. A recurrent nature leads to the loss of their reproductive story, a loss of purpose, and is accompanied by a roller coaster ride of emotions, as so clearly evident in this quote. Let's start off with the definition. A pregnancy loss is a spontaneous demise or loss of a pregnancy from conception till 24 weeks gestation. Recurrent pregnancy losses can be subdivided into primary and secondary losses. A primary RPL is recurrent pregnancy loss without a previous ongoing pregnancy beyond 24 weeks. Secondary RPL is a RPL after one or more previous pregnancies progressing after 24 weeks. Guidelines differ with regard to the pregnancy diagnosis confirmation, the number of losses, and the consecutive nature of these losses. We will be paying attention to these three main guidelines: ESHRE 2017, ASRM 2013, RCOG 2011. You will see that ESHRE requires the confirmation of a pregnancy with serum and urine beta or urine beta ACG and excludes ectopic and molar pregnancies, where ASRM requires ultrasound or histological examination, and RCOG does not really define their inclusion criteria there. Weeks of gestation are fairly similar, and then the recurrence differs. RCOG includes 3 losses, where ESHRE and ASRM includes 2 losses. ESHRE differs from the rest, where they have now made the adjustment that they include consecutive and non-consecutive miscarriages. Their proof for choosing 2 losses and including both consecutive and non-consecutive miscarriages are that there's no physiological proof that it makes a difference or that it has influence. There's no impact on the prognosis in unexplained recurrent pregnancy losses. There's no association with increased risk for antiphospholipid syndrome. There's no difference in the probability of carrier status for structural chromosomal anomalies, and only less than 10% of recurrent pregnancy losses have 2 or more non-consecutive pregnancy losses. RPL affects about 1% of couples attempting to conceive. Previous miscarriages definitely increases your risk for future miscarriages. This is evident by our live birth success timeline, where the percentage of at least one live birth is reflected in relation to the background amount of recurrent pregnancy losses and the time after the first consultation. One can definitely see the difference, especially in the first 10 years, and from there on, a bit of a plateau. So let's look at the risk factors for RPL. As mentioned, previous miscarriages, then maternal age. Please draw attention to Table 2 on our slide, especially within the age group 40 to 44 and then above 45, with a doubling in miscarriage rate from 40 to 44, and then above 45, another 25% increase. Advanced paternal age is currently controversial, and a lot of investigation is being done in the field, and it is postulated that there is loss of sperm DNA integrity. It is advised that we counsel fathers above 45 years about this impact. Upon investigating lifestyle influences, it seems maternal BMI, obesity, and the opposite of the coin, being severely underweight, as well as smoking, has a negative impact on live birth. Excessive alcohol consumption has possible risk for loss, but definite risk for the fetus. There's insufficient evidence for exercise and caffeine intake, and I'm sure you guys have all had this question: does stress influence miscarriages? There is an association, but no evidence of a direct cause. RPL has a very broad and thoroughly researched etiology, but despite all of this, 50% of them are still unexplained. This contributes to the frustration of both the patient and the physician. The knowledge of this and sharing this information with a couple might be a very good start. Genetic factors have a major and often overlooked contribution, followed by anatomical variations, thrombophilias, and metabolic conditions. These we will discuss in detail, and then the immunological, microbiological factors, and male factors we'll just briefly explore. As mentioned, 50% of our RPL unexplained group has no identifiable predisposing factor. 70 to 75% ultimately have a successful pregnancy. This is good news, and share this with your patient. A previous second trimester miscarriage has a poorer prognosis and increases your risk for preterm delivery, stillbirth, and neonatal death. The genetic abnormalities can be split into parental and embryonic abnormalities. 2 to 5% of RPL couples have chromosomal anomalies. They can be balanced translocations, Robertsonian, or reciprocal ones, or they can be chromosome inversion. In the embryonic abnormalities, 30 to 55% of RPR couples are affected. This is usually aneuploidy, including trisomies, polyploidies, and monosomy eggs. Karyotyping provides prognostic information for subsequent pregnancies. The chance of a subsequent miscarriage with a reciprocal translocation is 50 to 70%. Robertsonian translocations, 30 to 50%, and with inversion, a 30% chance of a subsequent miscarriage. Let's pay attention to anatomical anomalies. First up is our congenital anomalies, our Mullerian tube defects. The prevalence in the RPL population is 6 to 7% in comparison to 2% in the general population, with the uterine septum being the top feature here with 44.3%. They result in first and second trimester losses and can also result in preterm labor. Our acquired anatomical anomalies will follow next. Uterine polyps, submucosal fibroids, synechia, all alter the contour of the uterine cavity and interfere with vascularization of the endometrium. With specific attention to uterine leiomyomas, it seems submucosal and intramural fibroids displacing the cavity are relevant. A recent retrospective study on IVF patients noted that intramural fibroids of more than 2 to 3% have decreased implantation rates, decreased clinical pregnancy rates, and decreased live birth rates. This effect seems to be secondary to the production of cytokines and growth factors. Uterine adhesions or intrauterine adhesions are uncommon but a definite established cause of RPL. They've got poor pregnancy outcomes with a 40 to 80% spontaneous miscarriage risk and a 25% preterm labor risk. After adhesiolysis, these outcomes significantly improve with 50 to 90% of term deliveries, a decrease in miscarriage rate. The prognosis correlates with the severity of the disease. Cervical insufficiency will be our last acquired anatomical anomaly to discuss. Here, a prophylactic cervical cerclage has not been proven to reduce the risk of RPL. If there's a history of a preterm birth or a mid-trimester loss, please offer the patient transvaginal cervical length ultrasound surveillance from 16 to 24 weeks, and if there is a cervical length less than 25 millimeters, insertion of a prophylactic cerclage is advised. If there's a recurrent history with a definite suspicion of cervical weakness, one can consider placing it, but there's no evidence of increased perinatal survival in placing it without any cervical shortening evidence. A prophylactic cerclage may also improve pregnancy outcome where there are congenital uterine anomalies, with a previous history of a pre-viable delivery or progressive cervical shortening. Factor V Leiden and prothrombin mutations can be associated with normal pregnancies and have little effect on pregnancy loss. Recent prospective cohort studies failed the confirmation of an association with RPL as previously suggested by case control studies. Antiphospholipid syndrome is definitely one to remember. It has the incidence of 15 to 20% in our RPL population, and it is of importance as it has proven effective management. Antiphospholipid syndrome diagnosis can be made with one clinical criteria and one laboratory criteria. Underneath the clinical criteria, we have vascular thrombosis and specific pregnancy morbidity, as one can see in A, B, and C. For the laboratory criteria, one tests for lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein 1 antibodies. Please remember that these lab tests have to be done on 2 occasions at least 12 weeks apart. The optimal time for the testing is still a bit uncertain, but it would be appropriate to do it 6 weeks after the loss or postpartum or even pre-conceptionally. In the presence of subclinical hypothyroidism with a TSH above 4 and a normal T4, there is an association with miscarriages. In the presence of thyroid autoantibodies, there is an increased odds of miscarriages even with a normal TFT. Treatment has shown improved pregnancy rates. Hypothyroidism is identified in 7.6% of RPL patients, and treatment with altroxin is advised with a therapeutic aim in your TSH level of less than 2.5 in the first trimester and less than 3 in the rest of the pregnancy. Uncontrolled HbA1 levels, especially in the first trimester, is at extreme risk for spontaneous miscarriages. This risk rises with the level of the HbA1c. And then, the new kid on the block, vitamin D. In vitamin D deficiency, there's an increased risk of adverse events. For example, preterm labor, gestational diabetes, small for gestational age babies, and then preeclampsia. There was a significant association with RPL. The suggestion is all women with RPL should have their 25-hydroxyvitamin D tested and normalized to 30 nanogram per ml preconceptionally to minimize pregnancy loss. This is new data and was only published after the ASRM and ESHRE guideline release. Hyperprolactinemia, PCOS, luteal phase deficiency, and diminished ovarian reserve all seem to have some contributing role in RPL, but they considerably overlap with implantation failure, and there's limited evidence-based successful intervention. Presumed maternal fetal interface abnormalities secondary to similarities in the HLA genotypes, HY antigens, and also embryotoxic factors, cytokines, and natural killer cells in the presence of T cells have all been postulated as part of the pathophysiological implications of immunological factors. An association with endometrial inflammation has been suspected but not yet established. It seems there has to be a chronic pool of microorganisms, and therefore TB, bacterial vaginosis, parvovirus, chlamydia, and mycoplasma can definitely be seen as culprits. With regard to male factors, elevated sperm chromosomal aneuploidy and abnormal semen quality is suspected. There's still quite inconsistent data about the role of sperm DNA fragmentation, but it seems that there is a 2 to 4% increased risk of miscarriages if there is abnormally high male DNA indexes. Now we get to our investigations and our management. I think the beauty of being a human is the ability to hope. This gives our patients the courage to try again, and on the flip side of the coin, it is our motivation for evidence based medicine to investigate and consider all options and to offer the best option possible. So, what does the guideline say about the management and investigations for unexplained losses? It's recommended to provide psychological support, folic acid supplementation preconceptionally to prevent neural tube defects, although it hasn't been proven to improve live birth rates. Remember our vitamin D and multivitamin supplementation. Exogenous progesterone is not recommended as proven by the PROMISE trial. Low dose aspirin and heparin hasn't shown any benefit. Lymphocyte immunization therapy, IVI, immunoglobulins, and corticosteroids has also not been of any value. With regard to IVF treatment, in subfertile couples, the success rate of IVF is about 30% per cycle. Therefore, it's not beneficial in our unexplained RPL couples without subfertility, as the chances of them having a successful pregnancy are greater without treatment than with, about 60 to 75%. If you have an advanced maternal age mother and recurrent pregnancy losses, yes, then there might be an argument for IVF and it will potentially improve a successful pregnancy outcome. There's insufficient evidence for intralipid therapy and granulocyte colony stimulating. A most recent guideline, issued in 2017, does not recommend routine parental karyotyping and the genetic analysis of the products of conception only for explanatory purposes. If a genetic cause is suspected or investigation preferred or clinically indicated, the following diagram I find provides an approach. If there is one miscarriage, no action is required. In the presence of a second miscarriage, obtain genetic analysis of the products of conception. If there is an unbalanced chromosomal translocation or inversion, perform parental karyotyping. If the products of conception is euploid, you continue with your normal recurrent pregnancy loss workup, and if aneuploid, no further investigation is required. Pre-implantation genetic testing and selected euploid embryo transfer hasn't been proven to improve live birth rate, and it is not very cost effective, but it can be beneficial in RPL couples where the one partner carries a balanced chromosomal translocation, or there's a previous child with an unbalanced translocation upon history or aneuploidy. And as mentioned, IVF with advanced maternal age and unexplained recurrent pregnancy losses can be beneficial with increased implantation rates, decreased miscarriage rates, but equal live birth rates. The recommended investigations for the anatomical anomalies of RPL pregnancies after a proper history, a clinical examination, and a 2D ultrasound are a 3D ultrasound with high sensitivity and high specificity, a sonohysterogram that's more accurate than a hysterosalpingogram. Remember your KUB ultrasound for our Müllerian tract anomalies, and then one can consider an MRI, but this should not be first line if a 3D ultrasound is available. And hysteroscopy and laparoscopy provide the benefit of direct visualization of the anomaly, but they are invasive. It is recommended to perform cervical length surveillance if there was a second trimester miscarriage or suspected cervical weakness. The recommended management, surgically wise, for anatomical anomalies is an ongoing debate. We are anxiously awaiting the results of the TRUST trial. This is the first prospective RCT of its kind. Retrospective studies evaluating the hysteroscopic septum resection has shown increased live births and decreased miscarriage rates. If one considered an intrauterine adhesiolysis, for which there is actually also insufficient evidence, one should take precautions to prevent recurrence. There is insufficient evidence for reconstruction of anatomical congenital anomalies. insufficient evidence for submucosal fibroids and endometrial polyp removal. There's also insufficient evidence for the removal of fibroids distorting the cavity, and then the surgical removal of intramural fibroids is completely not recommended. In considering our metabolic and endocrine factors, it is recommended to perform a TSH, a thyroid peroxidase antibody, and a T4 if the TSH is abnormal. In the presence of subclinical hypothyroidism, one has two options: either treat or repeat the TSH in 7 to 9 weeks, and if then more hypothyroid, please initiate management. In the presence of autoimmunity, if the patient is hypothyroid, please treat, and if she is euthyroid, there's no evidence for treatment. Remember the new kid on the block? Vitamin D. It is important to individualize patients and therefore their management plan. Please take a proper history to guide your investigations and to identify risk factors. The differences in the guidelines and their opinions leaves room to make an individualized plan. Most of the differences we've already addressed in our previous slides, but I'll just remind you of some of the important ones or ones that we haven't addressed. ESHRE for genetic investigations, ESHRE, as mentioned, doesn't recommend paternal karyotyping on a routine basis. And if the assessment of pregnancy tissue is done, it should only be for explanatory purposes, and then one should use a array CGH method to minimize maternal contamination. ASRM and RCOG still considers a genetic evaluation. For our thrombophilias, ESHRE doesn't recommend any screening unless there is additional risk factors in your history. This is also supported by ASRM, but RCOG still recommends factor V Leiden and protein S deficiency testing, especially if there's second trimester losses. With regard to male factor analysis, ESHRE has come on board and mentions sperm DNA fragmentation can now be considered where it hasn't been recommended before by ASRM, neither RCOG. And then very, very important, please remember for antiphospholipid syndrome, your low-dose aspirin prophylaxis to be started before conception, and then a prophylactic dose of heparin, either unfractionated or low molecular weight, to be started with a positive pregnancy test. Then just as a reminder again regarding the differences in management of the surgical corrections of anatomical differences, ESHRE does mention possible septum resection in the context of trials. ASRM does mention you can consider surgical correction of anatomical anomalies, and RCOG was of the opinion that there wasn't any sufficient evidence. Then in summary, if one has two recurrent pregnancy losses, please remember to do your antiphospholipid antibody screening as by criteria. Remember your thyroid abnormalities and uterine abnormalities, genetic testing if indicated or a preference to do so. Initiate your low-dose aspirin with your antiphospholipid syndrome as well as prophylactic dose of heparin. Initiate your altroxin for your hypothyroid patients, and remember lifestyle advice, TLC, and vitamin D. Although recurrent pregnancy losses are a common phenomenon for us as practitioners, it has massive implications for our mothers and their families. Therefore, Kurten et al. Investigated the needs of these patients with recurrent pregnancy losses. This is a very small survey, but it provides some handy tips in their management. The group of patients requested reliable information, the inclusion of both partners. They wanted recognition of the significant impact of their losses and attention to their physical and psychological needs. The Miscarriage Association has several videos to provide comfort and information. I could unfortunately not upload one of the videos for the presentation, but it had a profound effect on me. The crux of it, it is not just cells. It's a baby. It's their baby. Just say you are sorry. And then lastly, to summarize some important information. A rainbow baby is a baby that is born following the loss of another baby. In the real world, a beautiful and bright rainbow follows a storm and gives hope of things getting better. The rainbow doesn't negate the storm, but acknowledges it and creates something beautiful. Storm clouds might still be overhead as the family continue to cope with the loss, but something colorful and bright has emerged from the darkness. And then, please remember, October is Pregnancy and Infant Loss Awareness Month. Thank you very much. I've added my references for you guys, and may you have a fantastic day further on.